It's a disinhibition of the striatocortical-thalamic cortical circuitry. It's hard to say. And then they're finding more not just dopamine and serotonergic dysfunction, but also glutamatergic dysfunction in these disorders. We know that D2 blockers work for tics. We know that SSRIs work for OCD. I'm interested in autoimmune and inflammatory stuff. I'll talk about that. And these are sort of phylogenetic, kind of old behaviors that are sort of wired in, and for some reason they get disinhibited. This was a nice picture by an article by Tom Insel, basically showing that in OCD you have a kind of a prefrontal cortex, orbital frontal cortex, caudate, hyper activation kind of presentation. It's in your way. But the thing is some of the studies looking at set shifting and basically ability to kind of not perseverate when they put these through provocation paradigms and functional MRIs, they actually show a hypofunction in those areas. So it's some area I'm not quite figured out yet, but there's definitely something not working right. I think we talked about the neurobiology of aggression. There's support for like the low central serotonin being related, lesions in the prefrontal and orbital frontal cortex. What is pathological aggression? Dr. Collis talked about this, but it's basically inappropriate for the context and excessive. He talked about the predatory reactive. I'll skip over that, but we're going to be mostly focusing on the reactive. And we heard a little bit of the developmental issues out there this morning, but temper tantrums are very common in 3 to 5-year-olds. Shouldn't be medicated. I mean, you really have to deal with those behaviorally. And I can remember my son having some huge ones, and they're inappropriate. They're in the wrong place, wrong time, but you just have to deal with them as a parent. Otherwise, they will get worse. But kids that have developmental issues are probably more prone to these. Aggression and tics and OCD, these are all usually frustration tolerance, probably because they have executive function deficits. But a lot of times it's because of the OCD tics themselves. Either they're sensory overloaded, somebody's sort of interfering with their OCD, and then they blow up and react. I had a young man the other day asking when did he have his blow-ups, and it was usually when somebody was giving him a hard time at school, and he just, not aggressive in any other context, but he said, I just couldn't contain myself because it just frustrated me so much to be basically ridiculed, and it was being ridiculed by a teacher. This was a kid that I saw last week, 11-year-old white boy with OCD. He did not have tics or ADHD. He was seeing us for intensive CBT and a medication consultation. His primary obsessions were he just changed his clothes repeatedly, felt like they were dirty. Every time he touched something, they were dirty and have to keep changing them. His mother tried to intervene and redirect him, and he exploded on her. And it went on and on for 15 minutes. I think he shoved her. And then afterwards he fell asleep. And she said sometimes he'd sleep for a few minutes, sometimes he would just sleep till the next morning, depending on what time of day. But when he woke up, he was incredibly embarrassed and distraught, and would cry because he felt so bad for what he had done. So some of the things that you might see that I would like for people to think about, obviously parenting issues, how they parent the child. Sometimes parents don't know when to kind of back off and just let something slide. Traumas obviously increase the risk. Stress of the disorder, where they're just so frustrated and tired of having the tics or the OCD. Poor language, social skills, executive function deficits because of comorbid ADHD. Sensory defensive, and that's something we don't think about a lot, but these kids are often very sensory defensive, that sounds, lights, everything bothers them. Different comorbid conditions. Medications, and I'll talk about that a little bit. Infection, and actually I had a really interesting 2.5-year-old that every time he would get strep would bite all of his classmates at school. Treat the strep, the biting would go away. So we see some really weird cases. If you kind of dig deeper, you can find some of these kind of connections. Some of the kids have pain because of their tics. Tic disorders are more prone to having migraine problems, so that takes into a factor. Nutrition, I think, should never be ignored. You know, insulin swings, low omega-3s have been associated with more reactive aggression and impulsivity, and celiac disease. And I've actually seen a few kids with celiac disease in my clinic with Tourette's. And this is where I think, you know, as child psychiatrists and certainly pediatricians and such, really should be thinking about iatrogenic causes of rage and aggression. And I think when I see this, I see it a lot, because actually I'm doing a SSRI activation study in OCD, where we're putting kids on sertraline, fairly aggressive dosing, low dosing, and then placebo. And some of these children really change, and it's pretty remarkable. Irritability, mood variation, low frustration tolerance, edgy, snappy. These are signs of activation that you can get from SSRIs. You can get it from a lot of other medications. Any kids, you know, especially ones with developmental disorders, are prone to having these kind of reactions. I've actually seen it from guanfacine, you know, which usually is pretty benign medication. I've seen it from neuroleptics. I've seen some kids, when you put them on Risperdal, they get dramatically worse. The allergy meds are actually known to be associated with activation and dysregulation of their mood and their impulse control. And then seizure disorders. When the anticonvulsants are, you know, I almost got a black box because of behavioral issues. Got some of these slides from Kathy Budman, who's probably the most published on rage attacks in Tourette's. In her rage attacks questionnaire, the aggression was considered uncontrollable, mostly occurring at home, mostly at a parent, and they would describe antecedents as hunger, illness, stress, and being told no, or change in plans. One of my colleagues at my program had done this. I think he did this with the UCLA group, McCracken and Passantini, looking at kids that had OCD and tics, and mostly was trying to see if there was a signal with OCD kids. Not really a lot of difference. The tic OCD obviously is a little bit worse. Delinquent behavior is worse than the tic OCD. Aggressive behavior is pretty much about the same, especially in the tic disorder. And attention problems were worse in the tic disorder. Looking at comorbidity, obviously more anxiety disorders in the kids with OCD, more ADHD in those with tics, and more ODD in those that have tics. I'm not sure that I agree with that, so I'll go over that in a little bit. But hoarding, kids that have hoarding and OCD tend to have more aggression, so that's one thing that you might see as a kind of a phenomenology issue. Stevens actually did probably one of the only and first articles looking specifically at aggressive behavior in kids with OCD, and basically said that it was kids that had tics with OCD and ADHD that seemed to be more of the driving issue. And it didn't really seem to have a lot to do with other factors. I had 106, well more than that, but 106 that's in this series of kids that enrolled in my immune studies. And what I found is that at any one point in time, 73% of those that had OCD only had rage episodes. Any OCD, 62%, any tic, 55%, and ADHD seemed to be a little bit more of the driving. So I would support what Stevens found, that the OCD and ADHD seem to be driving the rage episodes. This is a huge sample looking at kids with tics. 37% had anger problems ever, and 26% had anger problems at that point in time. And the other main point there is that it's much lower in those that had only Tourette's. Explosive outbursts in kids with tics, basically, again, supporting the issue that it seems to be associated with comorbid psychiatric presentations. This is Kathy Budman's work looking at rage plus tics and no rage, and then what you see is higher rates of OCD, higher rates of ADHD, and much more likely to be treated with medications. And I just thought I would throw this out there because when you see some of these kids, it's pretty convincing that maybe there's something to this. And this is kids that have the pandas, the strep-triggered